So welcome, Dr. Manish.
Good afternoon. Thank you for joining us as we continue with our webinar series from Vascular and Interventional Center about different medical conditions that we treat and the newer treatment options that we offer to our community. I'm going to talk today about pain management. Pain. Now, pain is something which affects almost all of us. We always have some part of our body causing us pain, and it's one of the commonest reasons that we go and see a doctor for. So there are pain can affect any part of the body, as you see in the chart here. The common pain that we experience, almost all of us, including myself, would be like a knee pain, a shoulder pain, a back pain, or headache. At Vascular Interventional Center, we have now started offering you a lot of newer treatments for treatment of pain, which are complementary to medication and physical therapy, and to prevent open surgery, which used to be the last resort if the medication or the physical therapy or a physiotherapy failed to address the issue with pain. I'm going to talk one by one about each of these conditions, and also, as you can see on an overview on the chart, what are the different treatments that we offer, and I will elaborate on them as we go along. One of the commonest things that we all of us encounter after a certain age is pain in the knee, also because of degeneration, also medically called as new osteoarthritis. As you can see on the left side amongst these two pictures is the diagram of a normal knee joint with a normal knee space and intact bone and cartilages, which is the covering of the bones on the knee joint. If you see on the right side, there is damage to the cartilage, there is overgrowth of bone and reduction of joint space. And this causes us a lot of discomfort depending on how old you are and how's your body weight. Commonly people start getting pain in their 40s, and it gets progressively worse as we get older and older. I'm going to ask you a poll question amongst the audiences, and I'm going to ask you three separate questions, and it would be good for the audiences to give in this poll question about their experiences with pain, with 0 being no pain and 10 being worst pain in life. So, how much pain do you experience when you go up and down stairs? This is the first polling question. Okay, second question. On a scale of 1 to 10, how much pain do you experience when you walk on a flat surface? Okay. Third question. On a scale of 1 to 10, how much pain do you experience when you're standing upright? We will wait to hear from our audiences and see what they say. Excellent. Thank you for your answers. We will go through some of your responses at the end of this discussion. Now, what are the treatment options that we offer for, what are the traditional options? I've been practicing medicine for the past 26 years, and all we used to have was medication and physiotherapy for knee osteoarthritis. And this was exactly what, and if it did not work, we used to offer patients surgical knee replacement. Now, the surgical knee replacement, of course, involves an invasive procedure. Full recovery can range from few months or entire year. It's not really the same, and still some patients can still have pain after the joint is replaced. Now, this is where the minimally invasive treatment options come for treatment of knee pain or osteoarthritis. A lot of these procedures we can actually do in clinic. A patient comes, we have a look at the patient, and we can actually offer some kind of a treatment within the clinic itself to help. Of course, there are stepwise approaches as we go along. So either we do it in the clinic, or if it doesn't work, then there are slightly more invasive options for which you need to be admitted as a day surgery at a place, and then you can go back home in about 3 or 4 hours after the treatment is done, and you're back to normal activity the following day. This is especially for patients who do not respond very well to either medication or to physical therapy like the physiotherapy, acupuncture, some of the other treatments, and still have a long way to go before considering knee operation. For example, say a 55-year-old person comes with knee pain. You've tried physiotherapy, you're trying medication, then what do you do next? You're not really, you're young for a knee replacement surgery unless the changes are very bad. So this is the kind of group of patients in which these treatments are extremely, extremely helpful. Of course, it is a custom-made treatment. There is no single treatment fits all. Every patient is different. So there are different interventional, minimally invasive treatments available. One is the knee joint injections, which we can do in clinic. We can do nerve ablation or nerve injections, which can again be done in clinic. A nerve ablation is a more second line process which involves ablating the nerve, which needs a day surgery admission, and also the genicular artery embolization. Of course, all these treatments are different, and we discuss in the consult and we assess and decide what's the best possible treatment for you. Coming to the next thing, which is shoulder pain. A lot of us have shoulder pain, very common in the right shoulder. A lot of us play different sports. I play sports, and we get shoulder pain, which is something which affects us a lot. Sometimes it prevents us from doing things that we really like to do. There are different types of shoulder pain. It can be osteoarthritis pain, it can be frozen shoulder pain, or rotator cuff injuries. Treatment options again include either physical therapy or medication, which are basically temporary pain reliever. A lot of pain medication, for example, the common pain medication that we take, they are best given only for up to about 2 weeks. After that, there is effect, there is possible risk of damage to the kidneys and stomach problems and stuff like that. So these are all temporary pain measures, and of course, physiotherapy helps. But a lot of patients do not respond to these treatments, and they may not be suitable for surgery, and or they avoid doing a surgical procedure. Now, surgery, of course, is again very invasive. It can be arthroscopy or it can be shoulder replacement. This is where the role of minimally invasive treatments comes across. These are all, like I mentioned, for the knee as well. These are minimally invasive treatments, either done in clinic or done as a day surgery procedure for up to 3 or 4 hours admission to a center. There are of different varying invasive procedures, but most of them involve needles and imaging guidance to treat these conditions, and you are back to activity within the next day itself. And they are best for people who are still a long way to go for surgery, or they do want to avoid surgery at all possible costs. The treatments that we offer are either injection into the joint, which is one of the more traditional methods of treatment. Other is suprascapular nerve ablation, which is injection of the nerves which supply the joint. This can provide relief for almost 6 months in a large number of individuals. Or the latest technique which has just come about in the last 2 years, which is embolization, which is dealing with the blood vessels which are actually causing the pain and discomfort to the patient. All these options are available, and they are tailored depending on each patient. After they are reviewed, what's the best form of treatment depending on that particular patient. Another very, very common condition, back pain. Almost all of us have had back pain at certain times in our life. There are different reasons. You can have lower back pain, you can have neck pain, shoulder, upper back pain, or the chest level pain is a bit less common. The commonest being the lower back pain and the neck pain. It can result from narrowing of the canal, with narrowing of the nerve roots as they come out. It can be because of slip disc, which is a very, very common condition. All of us have some degree of slip disc as we get older because of normal degenerative changes on our spine and as with a normal posture. That may be the reason I'm sitting so upright. So we're trying to prevent back pain by excessive pressure on a disc, or it can be because of vertebral fractures, which are more common in older people because of loss of the bone substance, of the density and decrease in calcium in the bone. There are a lot of treatment options. If I see a patient with back pain, what do I do? Most patients, I would give them some medication, some physical therapy, send for a physiotherapist, try to build the muscle, relieve the pressure on the spine itself. And by and large, about within 6 weeks, a lot of patients get better with this kind of treatment. Second line treatment is interventional pain management. These are done as day surgery procedures, generally either totally awake or under IV sedation or a light sedation. Basically needles are used to treat these conditions, and they're useful when even after a few weeks of physical therapy and after medication, the pain is still not gone. And this is like as the intermediate line before going for surgery. A lot of patients ask me, how long do these treatments last for interventional pain treatments? I would say each patient is different. Some will have good response for up to 3 months, some up to 6 months. Some people actually have such a good response that they actually do not need anything else, then they go back to their normal life along with physiotherapy, of course, at the same time. While I've had patients who haven't responded to treatment at all, but those are far and few in between. So a lot of patients do, in my experience, respond to these treatments. Surgery used to be quite an invasive procedure. Of course, we all want to avoid major surgery on the back and try to not have risk associated with big major surgery. And is one of the reasons all these treatments are in place. What are the treatments that we offer at our center? We offer non-surgical spinal injections. There are different types of injections that we do. We can inject the joints. We can joint the space around the spine. We can inject the nerves around the spine. There are different injections depending on how the patients are affected. Other thing we can do is radiofrequency ablation, which is involves going in and burning or blocking the nerves which are responsible for the pain. Another relatively newer treatment option which has come in the past 10 to 15 years. And the third thing where we can offer is a lot of times, last time we used to actually physically remove a disc or fuse a disc, but nowadays on a lot of patients who are actually suitable depending on their imaging and symptoms, we can actually put needles under imaging guidance into the disc itself and can ablate the disc with very, very good treatment outcomes in a large number of patients. Headaches, my colleague and partner has already spoken to you about headaches. We know it's a very, very common health problem. A lot of us have headaches, especially females. Extremely common to say I've taken time off work because of migraine today. Is one of the common reasons that we go to a GP. Now, there are a lot of medication for headache, of course, common being like over-the-counter drugs like Arcoxia or Brufen or paracetamol is one of the commonest things that we take for headache. A lot of patients do not respond to them, and you take medication, then every day you still have new episodes of pain. In those, there are some of the newer treatments available. There are some of drugs which are available to prevent headache. There are drugs which are injectable drugs which you can take on a regular basis. But still, there's a large number of patients who either have side effects or do not respond to medication so clearly. So these are the patients where interventional headache management techniques are very, very, very useful. Now, how do they help? They're basically done in the clinic, just like you come and see for a consult. Same way you come and see for headache. We do an assessment and see what medication you're on. They're done as a complementary techniques done in clinic itself. There is no need to get admitted. It takes about 15 minutes. We can do non-surgical nerve injections under ultrasound guidance in clinic or just based on the clinical profile. So injections done through these 30 gauge needles which do not cause any discomfort or pain. We can do Botox injections to deal with these areas, and you can have relief in symptoms as soon as within 15 minutes after the injection is done. And some of these can cause long-term relief, can be up to 6 months, which is quite significant if you're taking medication every day or you're getting side effect to medication. Now, what are the procedure expectations that one should look for when you come for treatment? The newer treatments for pain, it's an option for patients which is where pain is not relieved with medication or therapy, but we still do not want surgery. And of course, surgery is not always helpful for all patients. They still can have pain after the surgery is done. All these procedures are performed in clinic or as a day surgery procedure. They are either performed in light sedation, and the ones who do need sedation are discharged within 3 to 4 hours from the center with back to normal activity within 1 to 2 days. There is minimal pain or discomfort. You basically are not aware of what's going on. You come in, get it done, and you walk away 4 hours later. There is no surgical scar, and there is very, very quick return to normal activities if these treatments are effective for you. Thank you for listening to me, and I would look forward to some questions from you at the end of this talk. Thank you.
We will now invite Dr. Manish to take on some questions. Hi, Dr.
Y-
Manish.
yes, hi, can hear
Okay,
me?
so we
Mhm.
have some questions from the attendee. Okay,
Okay.
so is it possible to recover from annular fissures and disc bulge at L4 and L5, and how to prevent lower back pain relapse?
Okay, so that's a very good question. Annular fissure is a condition, and the disc bulge. There are two different spectra. So there are actually different ways a disc gets diseased in the spine. One is can just have a disc bulge, means the disc just becomes big and starts pressing on the nerves. Then disc has two parts. One is the outer fibrous covering and on inside jelly-like material. So there are one way is like I just mentioned, the disc can get bigger, it can bulge like a whole thing can balloon out and because pressure. The other one is called as a annular fissure, whereby there is a tear in a outer layer, the fibrous layer, and the jelly portion come out. Now, that jelly portion can come out in three ways. It can be what we call as medically small, large, or a very big protrusion. So we call it protrusion, extrusion, and sequestration medically. Now, what happens is those are the patients who have severe sudden back pain. Like, one of the classical histories is that I bent down, and after that, I had to pick up something, and after that, I just had severe back pain, and I cannot straighten my back, or I have a pain with radiating pain down the leg. So there are two different pathologies here that you asked. One is annular fissure and disc bulge. The answer is both. A disc bulge usually will not recover fully because there will always be some disc bulge, but annular fissures can absolutely recover over period of time. They become like scar tissue back again. Sometimes you can have disc bulge and no pain, so it doesn't mean that if you have bulge you will always have pain. So it's answer to your question is most patients will recover from either fissure or bulge as far as symptoms are concerned, not on the MRI alone. How do we prevent from lower back pain relapse? Of course, important things, the posture, spine posture, how we sit, how we look after our back. And most important is you learn some back strengthening exercises from your physio and you continue to do them at home on a daily basis. There are some very nice back strengthening exercises in yoga as well. So you can learn and you can do them on a regular basis. That one will prevent lower back pain relapse.
All right, thank you, Dr. Manish. So, the next question is: I'm having neck and shoulder pain that I could not even turn my neck or get out of bed without lifting my head. I exercise often, and I'm in my 50s.
Okay, so what happens is that one usually a lot of times is because of bad posture at sleep and what we call as a muscle spasm. So for these ones, there are two ways. Of course, we need to see how things are. So one option is, of course, when you have acute spasm and you cannot turn your neck, then sometimes you need medication for some time and also need a scan to see how bad the spine is. Based on that, we decide from there. And of course, long term, if it's a problem, like sometimes you will say, oh, we have constant issues with the back and neck pain, and also that one will send for physio to learn some exercises, and also we teach you some exercises in clinic to do, which helps to strengthen your muscles in the neck area.
Ah, okay. So last question. I had a rotator cuff tendon surgery 6 years ago. Can I get aches and pain from it again? And what shall I do?
Okay, so of course, after rotator cuff, you would have been sent for physiotherapy after that. Now, sometimes the symptoms can recur. Either the original changes which were repaired, there is some new change. So one option is to assess how bad is the pain, whether it's a mild, moderate, or severe, or is it the same pain as you had before at the time of surgery. Now, if it's a pain which is similar as before, it may be some new changes. Then, of course, we'll do a normally a MRI and see if there are any new things going on. Other than that, we look at physio, and then also some of the other treatment methods that we talked about in the talk earlier about doing injections, doing NSTRIDE injection. We can do some injections for pain, and then this new technique of embolization, which is quite helpful. Last few patients, we've had some very good results because they were very symptomatic. Of course, each patient is different, and it will depend on the symptoms that we see when we see in clinic.
Okay, thank you so much, Dr. Manish.